Hello everyone, you're watching sqadia.com. Now the question is, how would a patient with AVN of the hip would present? Would that patient be a child? Would that be a young lady? Or that would be an old man? That is a very important question. The point is, it could be depending upon the reason. It could be a young person or it could be an old age. If it's traumatic cause, that is after suffering in road traffic accident, usually the traumatic AVN is in young population because they have suffered a high energy vehicle impact resulting in some kind of a fracture neck of femur or acetabular or pelvic fractures. But if it's a systemic disease like thrombocytopenic purpura, SLE, Gaucher's, other sickle cell disease, they usually then patients actually there is no history of trauma, but the patient usually of old age and present with internal changes resulting in AVN of the hip. In this, we will be going through the general aspects. What is AVN or osteonecrosis? Then epidemiology, in which population it is more common, in what age group it is more common, and what actually age population is affected the most. Lastly, we're going through the demographics. So what is osteonecrosis? Actually, osteo means bone and necrosis means infarction. It is actually the necrosis of the bone. Why would that occur? That would be when the blood supply to the bone is actually cut off. And then it's the reason that, for example, there are certain joints in the body. Hip is most common. The other includes the femoral condyles. Then there is a scaphoid, there's talus. These bones are actually more susceptible to damage. Why? Because of their anatomy. Sites which are more susceptible to ischemic necrosis include femoral head. Why the femoral head is more susceptible and most common cause of AVN is because if you see the anatomy, there is only some part of this blood is supplied by arteries to the ligamentum teres, which is around the fovea capitis. Most of the blood supply is actually coming from outside the capsule, that is via medial circumference femoral artery and lateral circumference femoral artery. By the age of 4 years, the majority of the blood supply going to the head is through the lateral circumference femoral artery. By 8 years, actually the blood supply to the head is mostly from the medial circumference femoral artery. So if that is actually affected, or in case of fractured neck of femur, in traumatic osteonecrosis, what actually happens is these retinacular vascles which are actually entering into the capsule get torn. So once the blood supply is stopped, there would be a chance of avascular necrosis of the femoral head because very small part of the blood supply is coming from the artery to the ligamentum teres. Most of the blood supply is coming from the medial circumference femoral artery, which is lying outside the capsule. Coming to the femoral condyles, they can also be susceptible, although there are a lot of genicular arteries and a lot of genicular anastomosis around the knee. But femoral condyles can also get necrosed, especially post-trauma. And the head of the humerus. In the humerus, we have a similar mechanism. We have circumference femoral arteries which are actually running. If they get damaged due to any cause, this can cause to the result in the loss of vascular supply to the head of the humerus. Then is the capitulum. This is also a very small bone in the elbow, which can, if during elbow dislocation or traumatic incident, if it gets damaged, this can lead to osteonecrosis. Then proximal parts of scaphoid and talus. So that is important. Now, talus, if in case of a fractured neck of talus, the vascular are going through the initial proximal part into the neck and then to the head of the talus. The head of the talus becomes necrotic because now the blood supply is being cut off. Similarly, in case of scaphoid, it has a proximal pole, it has a base, and it has a distal pole as well. Actually, the blood supply is coming from the distal pole towards the watershed area, that is a waist, and then to the proximal pole. If there is a fracture of the waist, or if there is a fracture of the distal pole which results in the cutting of the blood supply, usually the proximal pole becomes necrotic. Now these are the different diagrams which are showing different types of osteonecrosis. If you see, this is the knee, and if you see over here, there's a medial femoral condyle. As you can see, there's increased sclerosis and subchondral fracture which can be seen due to the collapse and fragmentation of the bone. Similarly, in case of talus, it is this the neck area, which is the most common. In case of a fractured neck of talus, the blood supply is going from this area towards the head, and once this is torn, the blood supply to this area, which is showing increased sclerosis, especially the dome and the head of the talus, they become necrotic. Now this is radius ulna, and this is the capitulum. This has actually degraded and fragmented into multiple pieces. Why? Probably because the blood supply following a post-traumatic event has been reduced. Now, subarticular regions actually lie at a more distant part of the bone's vascular territory. Now, if you see it over here, the blood supply is coming from this direction and going into this. So, the most problematic area would be for this part to because this is actually furthest away from the blood supply. There is small artery called as artery to the ligament teres, which is around coming over here and supplying a very small area of the fovea capitis. But this superior lateral part, which is actually the farthest from the blood supply in the case of the femoral neck, is that is why if there is anything goes wrong with this blood supply or it gets cut off, the first area to get affected would be probably this area, which is at the far end of the blood supply, especially the subarticular regions, enclosed by cartilage and giving restricted access to local blood vessels. So the important point is the cartilage does not have its own blood supply. It actually absorbs nutrients and oxygen from the surrounding tissue, but what happens is the bone needs blood supply. But if the cartilage probably can survive for a longer period, but bone cannot. So if the blood supply is cut, this results in actually the necrosis of the bone. Now, what happens is for example, just take the example of a traumatic event. Patient had an RTA, resulting in fractured neck of femur, and now what has actually happened is that there is a disruption of blood supply. What is there is actually the retinacular arteries which originate from medial circumfemoral artery were going into the capsule have actually torn because the capsule has been torn as well due to the damage to the fractured neck of femur. Once that happens, there is the arteries vessel gets torn, there would be definitely hematoma formation. As you know, it's a capsule is a closed structure, so once the blood gets pulled in, this results in increased intracapsular pressure. Now once this pressure due to hematoma, that would be increased to a value where it causes the veins to collapse. Now from then first it would disruption of the local blood supply. This would lead to venous stasis and retrograde arterial stoppage. As further, because now the blood initially the blood cannot come in, now the blood which has already collected due to fracture and hematoma formation, it has actually caused the veins to collapse. So therefore the blood which is already has arrived cannot now go back. This would further retrogradely impair the arterial supply. Once that is done, there is a stasis and the blood flow to the arteries becomes sluggish. This results in intravascular thrombosis, that the thrombotic event starts to occur, which further hampers the blood supply, which is already compromised, leading to compression of capillaries and sinusoids by the marrow swelling. Eventually what happens is once the blood supply is stopped, this leads to further basically venous stasis and sinusoid get engorged, then getting engorged resulting in a marrow inflammation, and all this actually further and further this kind of vicious cycle which keeps on compromising blood supply until the bone becomes necrosed because it's a closed compartment. Now this is exactly showing how the disruption of arterial supply can take place. For example, in case of a fracture neck of femur, now once this has occurred, this hematoma collection, this causes intercapsular pressure to rise, leading to venous stasis. This may cause the sluggishness and eventually thrombosis, and lastly the compression of capillaries and sinusoids leading to further swelling, and this is actually a vicious cycle which eventually completely stops the blood going to the bone. So what actually starts is, now if it's not traumatic, it's a non-traumatic this could be happen in multiple diseases. For example, in case of sickle cell disease, when the hemoglobin, they have a problem with the hemoglobin, so as a result, when they're exposed to low oxygen tension, they become the RBCs assume a sickling shape. That's what's called a sickle cell disease. And there is a dysbaric ischemia, which occurs in the deep sea divers, because they are using nitrous oxide sometimes as well. So when the nitrogen actually goes into the blood, this not only causes increased thrombosis and casein disease, a dysbaric osteonecrosis, but this actually also clogs the vessels, which is and leading to AVN. Then in case of thrombocytopenia, the same process goes in. Although there is no trauma, but the stasis has actually caused the thrombosis of the vessel, leading to stoppage of circulation. Similarly, in case of the fat embolism, the fat globules actually block or clog up the microvasculature, leading to AVN. So these all diseases actually first cause arterial occlusion. Then this causes, the same cascade is repeated. There is then venous stasis, and thrombosis, and then eventually leads to marrow edema. Now marrow edema would further actually decrease the arterial occlusion, because it is actually increasing the intercapsular pressure. Then this leads to sinusoidal compression, which is actually sinusoids in the bone. This compression leads to directly to the further vascular status, and then further arterial occlusion. So that is kind of a vicious cycle you enter into. In case of Gaucher's disease, tuberculosis, or in alcohol or cortisone, sometimes they directly affect the sinusoid. There is increased sinusoidal compression. Then there is a vascular status, which actually increases the pressure, intra-compartmental pressure, leading arterial occlusion and marrow edema. So now coming to the incidence, it has 20,000 new cases of EN per year in the United States, accounts for about 10% of the total hip arthroplasty performed in a year. So AVN of the hip is a very important phenomenon, because economically, total hip replacements is a quite large amount of total hip replacement done due to AVN of the hip. Coming to the demographics, it's mainly between 35 and 50, but usually males are more common than females, and depending upon the trauma, usually traumatically, it's males have increased tendency than compared to females. Location, mostly it's the hip. The first and foremost is the AVN of the hip. Then it could also be multifocal, which means that there could be not more than one joint may be involved. But this usually not the case in case of traumatic and non-traumatic causes. For example, sickle cell disease, Gaucher's disease, and other thrombotic disorders. This could be multifocal osteonecrosis. There may be more than one joint involved. There may be hip, there may be knee, and there may be an humerus as well, or there may be a scaphoid. Disease in 3 or more different joints, and 3% of the patients with osteonecrosis are multifocal involvement. So what are the risk factors of the hip joint? Risk factors include the direct causes, which directly affect the hip, are indirect causes, which may be affecting a systemic disease, which is indirectly actually affecting the hip. Maybe radiation, that is for any tumor of the pelvis or acetabulum or lower spine. If that is unresectable, usually the radiation therapy is done. This radiation actually can damage the blood vessels, leading to osteonecrosis. Could be trauma, as in case of fracture neck of femur. Could be hematological diseases such as leukemia or lymphoma, because in these diseases there's usually hypercoagulable states leading to increased thrombosis. And there is dysbaric disorders, which is in which the nitrogen actually compresses the small vasculatures, leading to osteonecrosis. Or marrow replacing disease, for example, in case of Gaucher's disease, in which the marrow is abnormal, resulting in osteonecrosis. Sickle cell disease is also directly causing the cause of the AVN. Other indirect causes include alcoholism. Alcoholism can lead to peroxidative stress, because multiple free radicals are formed in the body, which can affect, resulting in bone infarction. Hypercoagulable states, steroids, which are most common cause of exogenous, especially because steroids are readily used for different treatment of arthritis and other diseases, especially these patients with who are on DMARDs and other drugs, can present with AVN of the hip post steroids. Other causes include SLE, transplant patients, especially because they are immunocompromised and they're specifically given steroids so that to prevent immune rejection, resulting in this they may be more susceptible to AVN of these, such as some viral infections can also indirectly affect AVN, and then diseases such as protease inhibitors, for example, HIV medications. It has been some research papers that this may cause the AVN of the hip joint. And other causes include idiopathic. Now we have just in this section we have discussed about what are the different causes of AVN and how actually this vicious cycle starts. That initially there is arterial occlusion. This leads to increased hematoma and increased intracapsular pressure, leading to venous stasis, and eventually this venous stasis would further enhance and causes sluggish blood flow, leading to thrombosis. Now this thrombosis is when the infarction starts, and this further results in a marrow edema, and this marrow edema, when there is edema, there would be further infiltration and there would be further increase in the intracapsular pressure, which would be further decreasing the arterial blood supply. So once this vicious cycle starts, it could be inciting event at one end, but then it will keep on progressing till eventually the bone infarctions occur. Thank you very much. Keep watching sqadia.com.